Now let's begin with these lines. वो खुद ही तय करते हैं मंजिल आसमानों की, वो खुद ही तय करते हैं मंजिल आसमानों की, परिंदों को नहीं दी जाती तालीम उड़ानों की, रखते हैं जो हौसला आसमां छूने का, रखते हैं जो हौसला आसमां को छूने का, उनको नहीं परवाह कभी गिर जाने की.
Ladies and gentlemen, as per the consensus report of rise in incidence of colorectal malignancies in the next few decades and the evident scarcity of dedicated colorectal surgery residency programs, there is a profound need for comprehensive training of colorectal surgeons in advanced technologies. Now, I would like to invite Dr. Rubab Nafis, Consultant General and Laparoscopic Surgeon. She has completed her MBBS in 2013 and has cleared FCPS in 2021. She has awarded Overseas Doctor Training Fellowship Program at Salford Royal NHS Foundation Trust. She is working as a consultant in Colorectal Disease Patient Welfare Association on honorary basis. She has a special interest in colorectal surgery and surgical oncology. Ma'am, kindly come on stage and please lead the session third of the day.
Thank you, Saja, for your kind words. Hi and good afternoon, everyone. We are going to start our third and last session of today. And every speaker will be given 10 minutes for this speech as we are short of time. And the question answer session will be held at the end of the session. I'm going to announce my panelist. Professor Qamar Baloch has is a professor of surgery, was a professor of surgery at Dow University of Health and Sciences. He has been worked as a chairman and dean of surgery and allied. And after his retirement, he joined as a medical director, Mehman Medical Institute, and now currently working at Al-Tibri Hospital. He has also been awarded as a member of faculty of surgery at CPSP and Society of American Gastroenterology and Endoscopic Surgeons. Professor Qamar Baloch. Our second panelist is Professor Asif Qureshi. Dr. Asif Qureshi is a professor of surgery at GMDC and is a consultant laparoscopic surgeon at Darussalam Hospital, Karachi. Our third panelist is Professor Farhan Zahir. Professor Farhan Zahir is a graduate of KMDC, is a fellow of CPSP since 2003, and is attached with Dow University of Health and Sciences since 2008. He is currently the current HOD of Colorectal Ward CHK Surgical Unit 5, and he has a special interest in laparoscopic surgery. Now I'm going to invite my speakers. Our first speaker of today's third session is Professor Abdul Razaque Shaikh. Professor Abdul Razaque Shaikh is a general surgeon, medical educationist, administrator, and researcher. He has worked for 25 years at Liaquat Medical University as a faculty of surgery and has been awarded as a best university teachers by HSC. He has been now working as a registrar at CPSP from June 2022. He has earned his MCPS in Health Professional Education and is currently attached with CPSP.
I'm grateful to the organizers for giving me the chance. Actually, the topic is not chosen by me, it's given by the organizers, just to talk about the upcoming fellowship in colorectal surgery by College of Physician Surgeons, Pakistan. This is the roadmap of CPSP that after MBBS, the house job, one has to pass the FCPS part 1, then register with registration and research CPSP, then year 1, year 2, then intermediate module, then year 3 and 4, and then the exam. Now this is about the first fellowship. And after this, the second fellowship starts. So we have got the two kinds of fellowship. One are the first primary fellowship, second fellowships. And as we have shown the chart below, that in 11 disciplines, there is a FCPS Part 1. We have got 80 specialties. Now it has come to be 81 really today. That we have got about 45 first primary fellowships, as you can see the long list, and then we have got the 35 second fellowships in FCPS. And MCPS, that membership we have got about 22, which includes the MCPS HP and healthcare management system. Definitely, I will not go to details of the rationale of the colorectal. That definitely this is very something very strong that every almost general surgeon is practicing colorectal surgery, and we have found that the colorectal disease are increasing, and especially the malignancies. We have to look for those malignancies definitely to diagnose early and treat early. So that's why it was decided by the faculty and proposed that one should come up with the training of the our trainees in the second fellowship. The aim is to residency program will be to train self and confident, competent colorectal surgeons, expert in their field. It is expected that colorectal surgeons produced by the residency program will be dedicated and empowered to contribute significantly. Now the duration of this second fellowship will be 2 years after this first fellowship. The eligibility criteria will be that must have passed FCPS general surgery and then registered with PMDC and in good standing with PMDC and CPSC both. Then these are the complete accreditation criteria. Should have at least one eligible colorectal supervisor as per criteria. Should have facilities. Now these are the criteria for the when we are going to recognize a unit for training of the colorectal surgery. Then these are the criteria. The people they ask what should be the criteria, that we should have at least one colorectal supervisor. There should be facilities in ICU, endoscopy and radiology, should have facility for oncology services, should be have designated beds for colorectal patients, should be designated OPD, should be have emergency facilities, and should have minimal invasive facilities. Now these are all criteria that any unit which have these criteria would be considered for recognition of training for second fellowship. The supervisor criteria, that 5-year post-fellowship in colorectal surgery experience, supervisor having colorectal fellowship or 15-year post-fellowship experience, or supervisor having FCPS, FRCS or Diplomate American Board or qualification and special interest in colorectal surgery, meeting minimum surgery workload criteria, completion of required CPSP supervisor workshops. We have got 4 supervisor workshops that he has to complete, and at least they have to submit the 50 MCQs also as per policy. At least 3 published research articles related to colorectal surgery in PMDC or CPSP recognized journals. Now this is the outline that we are undergoing the final touches, and hopefully that we are going to start in January 2023. Workload guidelines. What should be the workload? That should have at least performed 50 colorectal surgery procedures annually, the supervisor. The applicant has performed at least 150 colorectal surgery procedures as a primary surgeon. The applicant has performed at least 50 cases annually for at least 3 years at the time of submission of application. A single procedure can constitute a maximum of 10% towards the case count. Excess case may not be counted towards the total count. At least 5% of the procedure should be via laparoscopic surgery, that's minimal invasive surgery. The qualifying procedure, I will not go details of those procedures. There are common procedures like hemorrhoidectomy, internal sphincterotomy, rectal prolapse, neoplasms, and then stomas, diversions, and these are the common procedures being performed by the colorectal surgeon. At least they should give us the workload of these procedures they performed, and then we can certify according from the data from the operation theater, admission from the wards, and then we can say that they must be. Actually, the inspector who comes for this inspection is provided with a checklist. Actually, we have revised almost every checklist and every form for accreditation of the primary or second fellowships. And we have, according to the World Federation of Medical Education, we have revised those forms that have got the must, should, and should have. So the must criteria that I've shown you should have be very essential, otherwise the unit will not be recognized. Number of residents will be induction of 2 residents per supervisor at the time of induction, a total of 4 residents per year. Now we have got they can take the 2 trainees per induction for 6 months and 4 trainees per year. In general surgery, we have got 4+4 formula that if the whole unit is there, that is professor, associate professor, and assistant professor, they can take 4 for the primary fellowship and 4 for the going to other fellowships. But for the second fellowship, we have got the criteria different, that is they can take the 2 trainees per supervisor. So we have got very structured program, and we have got a chart made by the faculty, and they have to follow that chart, that 1 year, from first year they have to perform those procedures, second year, third year, and fourth year, and very structured program that has to be followed. And so definitely we are going for it is competency based again, technical skills, knowledge, research, communication skills, professionalism, teamwork. Again, I will mention that it's not time bound. Until and unless they have achieved the competencies, they cannot be passed. And one size doesn't fit all, as you know. One can have achieved those competencies 2 years, one can achieve in, say, 4 years. It depends upon the candidate, supervisor, and the training facilities. So definitely we are going for the technical skills, we are going for the non-technical skills and cognitive skills definitely, and then we can certify. The procedural, the milestones are that the observers, the trainee first observes, then assist, performed under supervision, and perform independently. Now, this is not the procedure that we advocate to be performed on patient. We say that they should have first training on some simulator, something like that, before they touch the patient. Otherwise, the patient's safety will be jeopardized. And definitely, this is the modern method of teaching rather than the 100-year-old Hallstadian method. And these are the competency charts that I told you that we have got structured. I'm sorry for this all busy slides. I've split it even in 2. So from first year, what the process they will perform from second year, third year, fourth year, and this is second part of that. And the supervisor has, these are given to every hospital which is recognized for training, and the supervisor must consider that these are done by the trainees, and they have to be record these all cases in their logbooks. And logbooks are to be seen by the CPSP, and then when they have completed their cases and educate cases, then we allow them to appear in exams. The rotations in second fellowship of colorectal are colorectal surgery 2 months, colorectal surgical 20 months, that is major, and minor gastroenterology for 2 months, radiology for 2 months, and special pelvic investigation for 2 months. That's optional. Sorry. So these will be things they will be doing in colonoscopy, anal, mandatory workshop, the research methodology, all workshops for supervisors, and definitely with that they must be very competent as FLS or that competencies for laparoscopic surgery that we have also started like ATLS. These are the research requirements, e-logs, and then syllabus. Exam format is a two-part. First MCQs and second is the 2 papers of MCQs, and then we have got the talks and long case and short case. All interactive sessions and talks. These are the long cases and these are the short cases. And this is the CPS. And thank you very much for your patience and listening. If there's any question.
Sir, being a faculty member of College of Physician and Surgeon, let me explain one thing. Sir has given the brief review. After getting the fellowship, they have, for the last 3-4 months back, they have started the fellowship in the hepatobiliary surgery. After that, I think one credit goes to the colorectal week and the COLOCON. They have made the, taste for the colorectal diseases and fellowship. So sir, वहाँ पर discussion in the faculty member हुई. So I have a little bit gave them a brief review that colorectal week and COLOCON ने जिस तरीके से colorectal surgery को enhance किया, and they made it. And second thing, when they have made the curriculum for the assessment के लिए, then I have already told them that we have the best global assessment tool in Pakistan in the shape of Professor Amjad, Professor Tahseen, Raza is here, so they can assess the assessment of the colorectal exam very well, and I'm sure they won't mind that. So this is the brief thing which I have given to the College of Physician, and I believe because of these 2-3 persons, we will have a very, very strong colorectal fellowship.
That's true. First, it's recognized or formed by the faculty, then it's referred to the Department of Medical Education, and then complete our form, then it's referred to the registrar. From registrar, it goes to the curriculum committee,
Yes.
and from the curriculum committee, it's approved, it goes to the council, and then it's approved. So it's a
So
long
it is
way
in
to
the-
go.
it
It's
is in
not
the
a one-day
process.
job.
And maybe said CPSP will take some views from the Professor Amjad and Professor Tahseen and Razaque about the curriculum and the assessment tool.
One question from Professor Razaque Saab that can you hear me now? One question from Professor Razaque Saab that how many centers you have identified for colorectal surgery, and number 2, how many supervisor you came to know which are identified till today?
Actually, I have deleted these 2 slides about the supervisor and the hospitals, because I do not want to disclose all these. Definitely the persons who are performing daily colorectal surgery, they have been identified, and the centers, but I don't want to disclose at this time.
But without identification, where people they will go?
No,
Actually-
we will
actually what
definitely,
happened
the process is that
is-
after the announcement, we will recognize centers. It will be on CPSP website, and then we will recognize the centers and name those centers on the website.
Sir,
When they are yet to be recognized,
Sir, yeah.
and then it will start.
Sir, actually what
Like
happened,
in spine surgery and in liver transplant, it went like a wildfire. And within 2-3 weeks, everything, it went through the whole country. Okay. You are right.
sir, actually,
So, my question is, we do a lot of colorectal work, and all that is almost all laparoscopic. This is the need of the day as well. So, एक humble सी बात है कि हम जो ज़्यादातर centers recognize हो रहे हैं, and again जो supervisors recognize हो रहे हैं, I think we need to train the trainers as well. Okay. So let's get out of. I know I'm too junior to talk about this, but unless we have a standard training program, तो वो चीज़ें जिस तरह चल रही हैं वो उस तरह ही चलती रहेंगी. So again, degrees मिल जाएंगी. जिस तरह breast surgery, I am sorry to say all this, but breast surgery के लोगों ने FCPS की training भी कर ली, सब कुछ कर लिया. They have never done a sentinel node. They have never done breast conservation. तो मेरे ख्याल के मुताबिक अगर इसको स्टैंडर्डाइज करना है तो we have to identify people who are already trained rather than identifying those people who are being made supervisor on the basis of their training experience and professorship. It's not going to work probably.
No, I must say that this list is not made by the registrar department. This list is recognized or approved by the faculty. And definitely while we are going for recognition, then I have taken this charge for the last 6 months. I have not recognized any center. To the best of my knowledge,
sir, I totally agree to whatever,
looking at district criteria. Okay, sir.
So I totally agree to whatever you are saying, but what the comment I am, as a humble junior, faculty member, what I am saying is that we have to, go beyond the traditional things.
Okay.
Otherwise, degree colorectal FCPS की सबको मिल जाएगी, और colorectal का काम आगे चलेगा नहीं. We have to identify people who are doing MIS colorectal. There are a lot of people who are doing it. There's not just a few people sitting around here.
Right.
बहुत सारे लोग कर रहे हैं, उनको आइडेंटिफाई करके सिस्टम को प्रॉपरली प्रोपोगेट करना पड़ेगा अगर हमने कोलोरेक्टल को आगे लेके चलना है.
We have actually identified the masters who are doing colorectal surgery performing throughout the country, and at least we have made it sure that should be public hospital, because major volume is in public hospital.
Sir, actually we are running short of time.
Okay.
Sir, Professor Amjad, please.
देखिए मैं आवाज़ आ रही है जी.
जी सर.
एक जो इम्पोर्टेंट चीज़ है ना किसी भी प्रोग्राम को क्रेडिबल बनाने के लिए, वो है ऑब्जेक्टिव असेसमेंट. ठीक है, मेरा प्रोग्राम मैं शोर मचाता रहूँ कि सबसे बेस्ट है क्योंकि मैं आपको बता रहा हूँ. अब कॉलेज या सोसाइटी अगर शोर मचाती रहे और कहे कि ये पीस ऑफ पेपर सबसे इम्पॉर्टेंट है, इट विल नॉट. तो ऑब्जेक्टिव असेसमेंट बिल्कुल इस तरह होगी कि जिसमें आप ट्रेनर्स को भी असेस करें और ट्रेनीज़ को भी असेस करें, और उसको ट्रेनीज़ की जो फीडबैक है ना एट द एंड ऑफ द ईयर, जब ही एंड शी कम्स बैक टू यू इन 2 years और कहे कि जी मुझे आपने प्रोफेसर चीमा के पास भेजा, 6 केस करवाए हैं, बस ये है उनकी ट्रेनिंग. अब चूँकि प्रोफेसर चीमा का नाम बना हुआ है तो अगली दफ़ा ट्रेनिंग उधर भेजने की ज़रूरत नहीं है. यू शुड एम्पावर ट्रेनीज़ एंड टेल देम कि जी आप ये रिपोर्ट करें कि आपका क्वालिटी ऑफ ट्रेनिंग क्या है. तो जो ये ओन ने बात की है, आई कंकर विद दिस, ये ह्यूजली इंपॉर्टेंट है कॉलेज के लिए अगर उसने अपने आप को प्रोग्रेसिव करना है. मेरा कॉलेज से कोई ताल्लुक़ नहीं है, मैंने ना यहाँ काम किया है कभी, ना मेरे पास फेलोशिप है और ना मेरी कोई ऐसी इंटेंशन है. लेकिन जनरली मैंने ये देखा है कि वी आर स्टक विद ट्रेडिशन एंड वी आर स्टक विद नॉट मूविंग द गोल पोस्ट, क्योंकि हमें लगता है कि शायद गोल पोस्ट मूव करेंगे तो हम अपनी रेलेवेंस छोड़ देंगे. ठीक है, तो मेरी एडवाइस यही होगी, ये मॉडल नया नहीं है. आपने ये जो मतलब फॉर्मेट दिखाया है, ये मॉडल दुनिया में हर जगह अडॉप्ट हुआ है. मैंने आपको सर्बियन प्रोग्राम का स्नैपशॉट दिया था. उन्होंने क्या किया, उन्होंने एप्लीकेशन मांगी ओपन फोरम में उन सेंटर से कि जो समझते थे कि वो इस काबिल हैं कि उन्हें रिकग्नाइज सेंटर बनाया जाए. यूके ने यही किया. जब हम पोर्ट्समथ में लैपको का सेंटर बने तो देवर ओपन एप्लीकेशन, 55 सेंटर्स अक्रॉस इंग्लैंड अप्लाइड एंड दे सेलेक्टेड 11. वो इसलिए 11 नहीं किए कि ये माइक टॉमसन बहुत सीनियर सर्जन है, पिछले 20 सालों से काउंसिल का मेंबर है, मेरा दोस्त है, तो इसके सेंटर को ले लेते हैं. उन्होंने कहा बताओ डेटा दिखाओ. पब्लिश क्या किया है, 200 रिसेक्शन साल की करते हो, मतलब और एंडोस्कोपी है, लेप्रोस्कोपी है, कैसे ट्रेन करोगे. ठीक है, आई थिंक कॉलेज शुड पुट दिस आउट द ओपन डोमेन ताकि ट्रांसपेरेंसी हो. मेरे ख्याल, ये मेरी हम्बल ओपिनियन है. तो I'll finish off and then of course I'll welcome your comment. और दूसरा ये कीजिए, जो मैं अगर इन पता नहीं बच्चे तो सारे चले गए हैं खाना खा के, उनको पता है कि सारे हमें शोर शोरी मचाते रहते हैं बाबे बैठे. एम्पावर दैम, इनको बताएं कि जनवरी में आ रही है पोस्ट, उसके लिए ये जंप्स हैं जो हूप्स करनी है आपको कंपेटिटिवली उसमें सेलेक्ट होने के लिए. ठीक है, वो फिर ऐसा होता है कि वो मुझे पता ही नहीं चला, वो सिलेक्शन हो गई, वो मेरे रूममेट था वो हो गया, मुझे तो मैंने तो ऐड ही नहीं देखा. जब आप इस कल्चर से दूर होंगे ना, देन यू विल गेट क्वालिटी. मेरा अपना ख्याल है कि इट्स अ फैंटास्टिक अपॉर्चुनिटी कि आपने रिकग्नाइज़ किया है, कॉलेज ने इसको एज अ स्पेशलिटी. आप रिसोर्स डेवलप कीजिए, 6 सेंटर डेवलप कीजिए, 8 की चलें. शुरू में यही होगा ना, हिट एंड ट्रायल है. जब काम शुरू होता है ना तो हम सारे चाहते हैं कि हम इस पार्ट सक्सेस का बने, क्योंकि हमारा राइट है कि हम मतलब बहुत बड़े प्रोफेसर हैं, पिंडी में बैठे हुए हैं, हमारे अलावा कौन कर सकता है यहाँ काम. ठीक है, आपको मैं कहूँगा, आप मेरे डायरेक्ट जानने वाले नहीं हैं, मैं खुर्शीद साहब को कहूँगा कि वो आपके जानने वाले ज़रा बात कीजिए. ठीक है, तो आप साल के बाद आपके पास इतनी एम्पावरमेंट होनी चाहिए कि आप साल के बाद पिंडी में बैठे उन साहब को कहेंगे किबला आपने वो सब कुछ नहीं किया जो आप डिलीवर करना चाहते थे, दिस इज़ गोना मूव. तब आपका प्रोग्राम क्रेडिबल होगा. और इसके साथ आई गो अ स्टेप फर्दर एंड से कि ये 2 साल यहाँ लोगों ने लगाए हैं, उसमें कुछ लोग जो ब्रिलियंट होंगे उनको इंसेंटिवाइज करने का तरीका ये है कि यू गिव देम 3 months 6 months ओवरसीज अटैचमेंट यूजिंग द रिसोर्स ऑफ द कॉलेज, ताकि वो लोग उसको मतलब पैशन से करें। ये
मैं आपके कमेंट्स के जवाब में ये कहना चाहूँगा कि ट्रांसपेरेंट सिस्टम है हमारा। जब अप्रूव हो जाएगी ना फैकल्टी, इसको हम अपनी वेबसाइट पर रखेंगे CPS में। उसके बाद में एवरी हॉस्पिटल इंस्टीट्यूट इन द कंट्री हैज़ द इक्वल राइट टू अप्लाई, एंड वी पुट ऑल द क्राइटेरिया ऑन वेबसाइट। दे फिल द फॉर्म, they send to us along with the fee, and then we see their form whether they have got all fulfilled all criteria. If they have the all criteria, they are ready, then we give them the inspection time. So this is our procedure. Second thing that you told that definitely the trainees are given the equal chances and the time. Definitely our induction will start for the whole month from 1st January to the 31st, 1st January to 31st January, and we can extend the time. Seeing that it has new faculty, recently we have launched spine surgery and liver transplant surgery, and there definitely
Sir, we are
there are a
running
lot
short
of
of
us for
time,
this.
kindly.
Sorry, I'm sorry, I'm not interested.
Please
But
invite
you
the
so
next
much.
speaker.
Yeah.
थैंक यू सो मच
Thank
प्रोफेसर
you, sir.
Razaque. I'm grateful for your insightful talk. एक्चुअली ये बात कराने का मकसद यही था कि यहाँ पर कंसर्न लोग होंगे और इस बात को आगे करना चाहिए. एंड वी वर टॉकिंग, द पर्सन हु वाज टॉकिंग अबाउट दिस वाज द पर्सन हु हैज मेड द करिकुलम. सो ही नोज एवरी बिट ऑफ इट. ही कैन टॉक फॉर आवर्स एंड आवर्स टुगेदर. लेकिन क्योंकि हमें इस हॉल के टाइमिंग्स का भी ख्याल रखना है, तो आई एम रियली ग्रेटफुल फॉर योर कंट्रीब्यूशंस. प्लीज स्विच टू द नेक्स्ट स्पीकर.
Our today next speaker is Dr. Raza Sayyed, who is a renowned surgical oncologist currently working at Patel Hospital with a special interest in colorectal cancer, peritoneal malignancies and soft tissue sarcomas.
Assalamu alaikum. Thank you very much for this opportunity. So the topic that I selected was how radical should we be for surgery for colon cancer. It was initially meant to be a talk centering around CME, but then I thought I found out that someone had already stolen the topic and is speaking before me. But many thanks that Dr. Irfan has covered most of the basics for what I am going to go through. I hope this is working. So, Bismillah ar-Rahman ar-Rahim. Fadabarakallahu ahsanul khaliqeen. So blessed is Allah, the best of creators. And God has created many things in packages. This shiny fruit of labor wrapped in this shiny package up to its core, containing seeds. It just reminds us of how many things that we in our surgical oncology career see as packages. And it does go down to how we look at the evolution of rectal cancer surgery. And Dr. Irfan talked about how the improvement in the outcomes came along with an improvement in technique. We do think of the whole context of this ayah that I recited, that how Allah developed a drop of semen into a congealed clot, and from that into a lump, from that into bone, and then flesh over that bone to make a new creation. And that makes us think about the embryology of how this convoluted current day anatomy of the small and large bowel comes into play. And when we look at it in real life, we look at how one single root gives rise to the whole package of mesentery for the small bowel, separate from the mesentery for the right colon and the transverse colon. And it's all this seemingly familiar anatomy and this complicated, convoluted embryology that we try and undo in our pursuit of excellence in obtaining outcomes for colon cancer. And this is what we basically look at. As we know that the preamble has been built that improvements in rectal cancer surgery led to an improved outcome, and that surpassed the outcomes for colon cancer, and there was a need for standardization for colonic resections. Hornberger actually demonstrated that performing a certain technique over a number of years improves outcomes, and he demonstrated an improvement in the outcome for colon cancer. The only thing is that the duration of this study was from 1978 to 2002, and there were many things that changed during that time. No doubt that this technique is really superior, and it takes out the embryological package along with the central vessels. But there were remarkable evolution in the systemic therapy for colon cancer at that time as well. So there are multiple contributors. Just like outcomes for rectal cancer, it was TME plus additional things, better imaging, better local treatment in addition to surgery that resulted in improved outcomes for advanced cancers. Similarly, for colon cancer, we have not just the technique, but other factors into play as well. Nick West and his group, in addition, following this lead from rectal cancer surgery and the pathological grading for mesorectal specimens, they actually looked at the definition or grading for mesocolon from the MRC Classic study. And we see that there are, oh, this doesn't work. But anyway, the top right of the screen is a muscularis propria plane excision in which the muscularis propria or the bowel wall is actually breached. And then the next specimen is an intramesocolic plane. So the bowel is intact, but there is a breach in the mesocolon that we talked about. And then the second one is a mesocolic plane, but not going up to the vessels of origin. And the bottom right one is a complete mesocolic excision. And they basically looked at a number of cases in their own institution and showed that the top curve, the top survival curve in each of these figures is the mesocolic plane excision, and the bottom curve is the muscularis propria excision. And they showed that the outcomes are clearly better if the surgery is kept in the mesocolic plane. So taking lead from that, the Denmark basically included all their centers that were performing. They got trained and started performing complete mesocolic excision, and they compared the Danish National Colorectal Database for patients who underwent CME compared to conventional colon surgery. And they found that the patients who underwent CME did better, all comers as well as stage 1, stage 2. The curves seem to merge towards stage 3, but there is still an improved survival that they showed. So it's all about specimen-oriented surgery that we talked about. And this whole thing, the concept is morphometry. The whole specimen is looked at. How much bowel is taken out? Proximal margin, distal margin. We all think about that and we talk about that a lot. But it's not just the only thing. The whole area of the mesentery or mesocolon is important. The distance from the tumor to the hyati, the distance from the closest distance of bowel to the hyati, they're all taken into account to have a look at the quality of the specimen himself. And that's what actually makes this the embryological package, just like a TME package that we try and follow. So the bottom blue plane is the visceral fascia and then the mesocolic fascia, and this dotted line in between is a way that we have to go through to separate the mesocolon from the retroperitoneal fascia. And if this plane is breached, like Professor Chima said, that there may be deposits that can spill over, lymphatic spillover. The spread may not be regional, it may be a peritoneal spread, but we don't know how this spread happened and we're thinking, oh, it's just bad disease. It may be a combination of factors in our technical performance of the surgery may have to be one of the contributing factors. So Japanese have been looking at it, like Professor Saab said, for a long time. This was a more recent study where a single Japanese center looked at the distribution of lymph node metastasis within colon cancer. And then, they just divided the pericolic or epicolic nodes and the intermediate nodes and the central nodes or the main lymph nodes. And then they looked at the distance from the tumor, the oral side and aboral side, from up to 5 centimeters, 5 to 10 centimeters, and beyond centimeters. We do see that for all comers, about 2% have central lymph node metastasis. About almost 10% have intermediate node metastasis. And majority of the other cancers that had lymph node metastases were in the pericolic or epicolic nodes. One thing that they found was distally, beyond 10 centimeters from the tumor, there were no nodes involved. And proximally, there were only 0.2% of the lymph nodes that were involved beyond 10 centimeters from the specimen. And that's why the Japanese classification and their guidelines recommend only a 10 centimeter margins, and the convention or the European or Western CME specimens usually have a larger specimen than that. And this, we could see that the central lymph nodes involvement in T1 cancers is 0, up to almost 15% in T2 cancer. So intermediate 15 and up to 4% in T4 cancers, central node involvement. And this distribution has been shown. It's more or less simple. 0 for cecum, the middle digit, 0 for cecum, 1 for right colon, 2 for transverse colon, 3 for descending, and 4 for sigmoid. And the third digit, 1 for epicolic or pericolic nodes, 2 for the intermediate nodes, and 3 for the central lymph nodes. And the package itself is defined by the location of the tumor and the vessel that feeds into it. The Japanese guidelines actually recommend a D3 dissection for all T3, T4 tumors or node-positive tumors, which are picked up on our preoperative imaging. The concept of nodal tears is important. I'll go back to this thing that if we say that only 4% or 1% or 2% are involved and taking them may not make a difference, it's actually, we have to look at the perspective that they look at, is that if the intermediate nodes are involved, then we have to go one tier above in our surgery to actually clear that regional disease. And that's the concept that they had applied in gastric cancer and had shown superior outcome. And this is what we're seeing them apply in colon cancer as well. And the other thing that Japanese guidelines and classification differ is that they define the extent of resection according to the feeding vessel. So up to 10 centimeters from the tumor, they would take on either side of the feeding artery 10 centimeters. If there is no feeding vessel within 10 centimeters from the tumor, they would still go 10 centimeters on one side of the tumor and 5 centimeters to the other side of the next feeding vessel. And then if there are 2 dominant arteries, then 5 centimeters to each side of the arteries. And if there are no feeding arteries, then the feeding artery or the artery closest to the tumor is taken as the vessel. It doesn't matter more or less towards the longitudinal extent, but it does define which vessel we're going to target if we're going to go for central nodal dissection. This is what I would want to dwell on, and it'll probably answer Professor Qureshi's question as well. This is the consensus statement on CME. The first reason that this all started was the colon cancer surgery wasn't standardized. Even CME itself is not standardized, and there are multiple different versions of it. And they came up, this group, the CME project working group, came up with a set of 23 recommendations answering each question. So with consensus, central vessel ligation is part of the CME dissection. For right colon cancer and transverse colon cancer, the right colic vessel, which feeds into the loop of the gastrocolic trunk of Henle, has to be taken. There is no consensus that could be reached about the right gastroepiploic vessel. So as far as the CME consensus statement is concerned, you're not, well, it's not sure whether you should or shouldn't. It may become a personal preference whether we should do it or not. We'll just touch on some of the outcomes, because these are prospective trials that are running and have produced their short-term outcomes. The trial, the RELARC from China, has shown an equivalent complication in grade 3-4 clavin endomorbidity. There were no mortalities, but a higher incidence of vascular injury in CME dissection. Only 3% of sentinel nodes were positive, and there were no cases of isolated sentinel node positivity. In the COLE trial from Russia, the short outcomes again did not show any difference between the short-term outcomes or morbidity. There were no mortality and 5% sentinel node positivity. We know that oncological outcomes, my review of literature actually missed out the study from Benz, but we have data from retrospective studies that the 5-year outcome overall survival ranges somewhere around 90%. We know from studies that have looked at this that the sentinel nodes, if they're positive, they confer a poorer survival. And for those patients who have sentinel nodal involvement, if it's N1 involvement, then following a CME-CVL, they have been shown to have a 71% recurrence-free survival, which is quite good. So there is a debate, and this will probably be answered by the outcomes that we see from the RELARC and the COLE trial, and hopefully will answer this question. To summarize, we know that surgery in embryological planes has shown to improve survival. We're still debating about the extent of lymphadenectomy, and it has to be case selection. The morbidity and mortality of these techniques have been shown to be acceptable in trained hands. And so gaining expertise and getting trained and setting up a training framework is very important. Standardized surgery will lead to improved outcomes, and the specimen itself can tell you how the surgery went. I would also like to share the Surgical Oncology Society conference, which will be in February this year, and we welcome you all to come and attend. Thank you very much. Questions at the end? Yes, if you're dissecting close to vessels, the incidence of injuries will be increased. But I think what we need to look at is that there were no mortalities. And when we look at the incidence of grade 3-4 morbidity, this was equivalent in both groups. So yes, the incidence of injuries is high, but they were all managed because they were being performed by trained surgeons.
Yes. With permission? Sorry. No. There is nobody above immunity. You mentioned the nodal status, which is a real crux. How do we preoperatively assess the nodal involvement on the current modalities? And the best published series with CT scan imaging, although they did it with MR as well, then didn't prove the figure, it's about 65%. And I think this is where the problem really lies, because how accurately you could predict preoperatively to go after those nodes. And they may be an overkill, and as we know, sometimes they look bigger and wider and you go after them, 4 hours of surgery, they all come back as N0, or they may be undercall as well. So I think there is a lot of work now in Europe, certainly. They're looking into radionomic signatures, trying to improve the preoperative imaging. Because as you know from Foxtrot trial data, we were contributing in Foxtrot from Portsmouth. और जनरली जो CT पे वो कहता था नोड्स हैं वो चले जाते थे कीमो के लिए, बाद में पता चलता कि नोड इसमें है ही नहीं थे, इसको कीमो की ज़रूरत ही नहीं थी. So I think you hit it spot on. जो मैसेज आपकी टॉक से जो मुझे मिला है, या जनरली मेरा ख्याल है जो बाकी लोगों को मिलना चाहिए, कि जो मीज़ोकॉलिक प्लेन की सर्जरी है ना, that is what is going to improve outcome for up to 90+% of our clonic tumors. जो आप बात कर रहे हैं ना 3 to 5% of central nodes, वो उन patients के लिए definitely ज़रूर है, और वो 3 or 5% अगर मैं और आप हों तो हम चाहेंगे कि हमारी CME हो, लेकिन ये है कि ये important है कि CME का concept लोग समझ लें और इसको भी इतनी respect दें जितनी rectal cancer को देते हैं.
Exactly. Thank you, sir.
Thank you, Dr. Raza. Our next speaker is Professor Qureshi. Sir, please come on stage.
A small request that we'll be cutting it very short, no questions answer at the end because we have few more things coming up.
Okay, Assalamu alaikum. To those who've remained, thank you very much. Can I make a small request? A छोटी सी request है मेरे से कि Taz जो है ये मेरा Anglified name है. जब मैं छोटा था ना तो कभी कोई स्कूल में कभी तहसीन नहीं कहते थे, हमेशा Tahseen होता था, Tahseen. तो थोड़ी देर के बाद आदमी को ठीक है Taz ही कह लो, at least get half the name right. So now I'm back in Pakistan, please feel free to use the name Tahseen instead of Taz. That's just a small request. So I'm going to stick to the brief, and the brief was that training the colorectal surgeon. That was the brief of this session. And I remember that when I was a trainee, it just feels like, you know, I'm going to take you on a journey, by the way, during this course. And it just feels like, you know, how am I going to cross the chasm? As a trainee, how will I get to the other side? You know, there's so many variables, so many problems. And by taking you on this journey, hopefully I'll convince you that it's possible, but there's a few things that you need to do. So what's the goal? The goal is expertise. And the first thing I would convince you to do is try to find the right expert. Everybody thinks they're an expert. You know, that's human nature, alpha male surgeons, most of us. But there are experts. I'll go back to school. We used to have some very intelligent teachers, but they couldn't teach. Because for things that were second nature for them, they couldn't process that children didn't understand this. So you might have a brilliant surgeon, but they can't actually translate that into training. You might have a very average teacher, you know, who can actually, because they have to work through things themselves methodically, and they might be a better trainer. There are some people that cross both bridges, but we won't go there. So look, before training, everything just looks chaotic. Everything, I've chosen this picture because it's a very small garage, and if you look at the picture on the left, it's almost like the abdomen. And unless you organise things, you know, you tell me where something is, you can't say where's what. But on the right, if you put things in an organised way, if it's methodical, we'll talk about modular training in a minute, it's the same space, the light is better, and okay, there's a lot of stuff there, but you generally get the feeling that I can figure out where I'd get what I want to get. So it becomes recognisable. So what makes an expert? We've been through these sorts of slides before. But I've said this to the trainees yesterday, that when I was training, I used to find it very frustrating that the same surgeon would do the same operation differently every time. How am I expect to learn from that? I can't learn from that. So you need a surgeon that does it in a boring way, the same way every time, okay? And that's how you will learn, and arguably with fewer cases. He turns the patterns into recognizable patterns, or she turns the patterns into recognizable patterns. And Professor Chima yesterday showed the picture of the Kremlin, and then the two pictures before then, which was a field and an electricity pylon, I think it was. The point was that was still Russia, that was still Moscow, but it's making things recognizable for you. I say to my trainees that, you know, if I haven't driven from here to Clifton Beach, I've never driven that before, I'll use my sat-nav. So when you're in theatre, your trainer is your sat-nav. The more times I do the journey from here to Clifton, I start recognizing, okay, there's that roundabout. You know, you start recognizing things and say, okay, I don't need my sat-nav anymore. And then slowly, you'll lose the need to have your trainer. It's having that trainer that makes you realize and appreciate what that pattern is. The technique needs to be reproducible. So in other words, there's no point someone coming on here and saying, look at me, look at how good I am. you're good if you can make somebody else do the same thing in the same way with the same outcome. And you need to make it look simple. And Messi, when he scores a penalty, it looks really easy, doesn't it? But you sit in front of 80,000 people in the stadium and probably about 4 billion people at home with all the pressure of Argentina and try taking the penalty, it's not the same. So you need to make it look simple. So training methods. This is key. I mean, this guy who's climbing that crevice, the first thing on his mind is safety. And look at his belt on the left. He might not need all those things, but he's prepared. And I mean safety for the patient. We have a responsibility to the patient as well as safety to the trainee. So safety first. And Amjad sort of touched upon these, so I won't dwell too long on them, but there is a laparoscopic template as to how we can treat, how we can teach people and fellows and trainees. And it's called modular training. And this is validated. It was published in way back when, 2011, by Amjad and his group at the time. And it's breaking things down into steps. Okay, so if you look at the marathon runner doesn't think, how will I do the 26th mile? He thinks, okay, I'm going to do my first mile, and then the second mile, and then the third mile. And each mile becomes more difficult, but you don't think about the most difficult mile first. You put things into an order. And that's sort of what we try to do with modular training. So with modular training, each operation, you can break it down into a number of modules, as I say, equivalent to the marathon runner. Don't think about the most complicated module first and give the most junior trainee that most complicated module. You judge that according to the proficiency of the trainee. Each module gets more difficult and it becomes simpler. If the trainee knows there's a step 1, step 2, step 3, step 4 for the operation, it just makes it simpler for them. And it's much easier to give feedback to the trainee in that situation. So this is just an example of a modular approach. I'm not going to go through this, but you can see there's increasing levels of complexity on going towards the right of the screen. And if you've got 3 trainees with you in the room, you can break each operation down into 3 operating opportunities or 3 training opportunities. So I think it was I've lost track of days now, when was it? Wednesday. One of the trainees did the pneumoperitoneum and the other trainee did a bit of mobilization, and that's what you do. Everybody gets something out of it. And, the most junior trainee did the suturing. So modular approach. So in conclusion, the modular approach is reproducible. It's giving a technique that's reproducible. It's much quicker to learn than the surgeon who does the same operation differently every time. If you've got a surgeon that does it the same every time, you progress your learning curve quicker. And having standardized techniques. And importantly, at the last, the safety question, there should be no difference in outcomes. I'll rush through this because Amjad went through this, but this is, you can measure metric data, you can objectively assess somebody and project them onto QSUM scores and decide how and when somebody's proficient. So those assessment scores are a great teaching tool. They shorten the learning curve, and we know what the modular approach does. So what I thought I would do is just give you the benefit of my experience. When you're a trainee, you think, the consultants, they just knew it all along. Well, the guy at the top of the mountain wasn't just put there. We've all worked hard to get to where we've got to. And I thought I'd give you my experience after I became a consultant, and that was in robotic training, because when I was a consultant, had no idea I'd be doing robotic surgery. So again, going through the template again, I said, right, the first thing I need to do is identify the right person, identify the right expert, and we know who that was. I took my time out when I was invited, and I tried to invite myself a number of times, annual leave, and went with Amjad to different units and just understood what he was doing, how he was doing it. I offered to be the bedside assistant. That allowed me to give familiarity with the robot. It's about, pride can't come into this. This isn't about pride. This is about wanting to do the right thing for yourself and the patients, and you do what it takes. And what I'm trying to impress on the trainees is it takes hard work. There's no getting around this. You can't get this from a textbook. So I've done this, which is why we say to you, do it as well. And then there are the online modules and the simulator. This is where I was lucky. There's a number of times I've been lucky in my life. And I work in a place called Poole, where there's a benefactor. There's a very rich person. He had colon cancer, and he decided to donate the robot to Poole Hospital. So we had a robot in Poole Hospital in 2015. So that called my bluff, because then I had to bite the bullet and I had to go through structured training. So what did I do? It's about going through a structured training, and identified a place, and it was EARCS, and Amjad had spoken to you about EARCS. Amjad set up EARCS in Lisbon, which is where he works now. And I had to beg, and I had to buy him lots of curries and clean his cars, and for him to accept me on the program. And finally, my mum convinced him to accept me onto the program. Okay, and so I went through this, and this was the training concept. You see, this is replicable in open surgery, in laparoscopic surgery, in robotic surgery. There's no difference. You know, application and courses will skip that. But it was supervised training, case observations, which I sort of already was doing because I was going with Amjad, and he was doing robotic surgery to different places, and that was my case observation. Hands-on in-reach training, he was good enough to come to Poole when we had the robot and take me through cases. And then outreach training, sorry, I got that the wrong way. In-reach training is when I went to see Amjad in Portsmouth, and with his team, saw how he did it as an expert and started doing things. And then and you know he goes around the world, and you know how he finds time, I have no idea. But then he came to Poole with my robot and my team and made sure that we were doing things safely. Once we were both happy, and like I say, it took a lot of boxes of Matai and things for him to agree to say I was safe. We submitted 2 DVDs, and they were independently assessed, and then you're signed off. Okay, so for the trainees, I've done this very recently with robotic surgery, so we're teaching what we preach, okay? Or we're preaching what we did ourselves. Now, a really important thing is to invest in your team. I can't just bring a robot to Poole and say to my team, right, tomorrow, that's it, we're going to be doing robotic surgery. You have to empower every member in your team. And that starts from the orderly, from the porter, from all sorts of people. And I often show this clip. Have you seen this clip? I don't know, but I'll show it anyway. So imagine, if you will, and thankfully the sound's not on, but imagine, if you will, the car that's coming is the patient, and the driver driving the car is the surgeon. Now look at the team. They're preparing before the patient and the surgeon have ever arrived. Look at all that work that's taken. That's, you know, we've got to respect the work and the effort and the training that's taken. Wait for it. Here we go. So here's the surgeon with the car, who then disappears into the sunset. And then again, look at the team. The team still has to carry on doing and preparing and all those things. Now, if any one of those members of the team didn't do their job, that car and the patient and the driver, it's going to be a disaster for them. So you have to invest in your team. And so investing in the team, for me, I could have said, well, the robot's just for the colorectal fraternity, and let's keep... But we opened it out to head and neck, we opened it out to gynecology. And what really helps is that if you've got other people fighting your battle, because the robot was only sort of promised for 3 years, but we wanted longevity, it really helps having a colleague or a friend or a person with you to help make sure that that success is maintained. So top tips for training. Okay, you have to practice lots. And I was saying to somebody yesterday, you know, that starts from the simple things, from tying a knot. You know, you have to convince your trainer that you're safe enough to be trained, and you know, do the simple things well. Everybody can, but just do the simple things well. Know the procedure. So look at the videos. You're lucky in the day of laparoscopic surgery where there are videos. You can have a look at the videos and just get some familiarity. Finding a trainer, finding the right person who, you know, you get trainers that maybe are slightly high profile. They like putting themselves on websites and this, or you get trainers that actually practice what they preach and they go around training people. Follow a structured training program, and I said this to Irfan, I don't know where he is, but it really helps having, once you're in consultant practice, having 2 of you doing things together, because a problem shared is a problem halved. And then hopefully everybody can make it look like this, you know, post-radiotherapy male pelvis. So in summary, you know, with that guy at the beginning of the Olympics when he's about to start the hurdles, can you imagine how daunting that must be? He's not thinking about the end. If he doesn't prepare and he hasn't prepared, that's what's going to happen. Poor preparation leads to disasters. But if he breaks that race down into steps, and look at the guy on the left with the yellow small sort of hurdles, you might think, well, look, I don't need to do that. But the point is, you go through a methodical structured training program, and by the end of it, you can do a big hurdle. And then hopefully by the end of the whole of your training, you can all jump hurdles. Some will do it better than others, but as long as the outcomes are equivalent, it doesn't really matter. Everybody finishes eventually. Just finally, a plea to the trainers. You know, invest in your trainees. It's very rewarding having people. Hopefully Amjad's got lots of little ambassadors around that he finds rewarding if he sees them successful, and it's true. You find people who are your fellows and they go out and they're successful and you're just happy for them. You develop a real bond with people that you've trained with or people that have trained you, and you develop lifelong friendships. And, you know, this is just some fellows together. Do you recognise anybody there? Guess who was the expert skier there? Any ideas? Just throw a name at me. Who is the expert skier? I'm going to very quickly see if I can go off piste, literally go off piste. Okay, the guy in the orange is Professor Parvez. And at the risk of embarrassing him, I'm just very quickly going to show a video. You know, the problem with Amjad is that, mashallah, you know, he does everything. It's so annoying. I'd love to hate him, but I love him. Because everything he does so well. If you play squash, he said to me once, I went round his house, come on, let's go and play squash. Thank goodness I didn't have my trainers. I thought, okay, what's he going to do? I stood in the gallery and I watched this guy warm up before he came onto the squash court. And I thank my lucky stars that I didn't, you know, ridiculous. You watch him play cricket. I'm sorry if you're embarrassed by this, but he plays for a place in England. He averaged one season, a century every innings. I mean, is there no end to this man's talents? So guess who this is? Look at this expert. Look at this expert, okay? So Professor Parvez, as if you've never seen him before. The point I'm trying to make is that you develop a friendship, hopefully it's reciprocated, and that's a bond, you know, and if you don't talk to somebody for 5 years, it doesn't matter. You pick up a phone and that bond's there. My fellows ring me all the time, but I hope you appreciate what I'm trying to say, that it's really rewarding to train trainees, and hopefully, as I say, it's reciprocated. You develop lifelong friendships. Thank you very much. I'm sorry if I've overrun. And hopefully you'll cross the chasm as trainees.
Professor Tahseen, I'm sorry we don't have time for questions, otherwise there was a lot of room for that. And my apologies for the repeated request to shorten up the timing and duration, because we have to hand over this hall. So may I request the final two speakers to come and please finish. Thank you. Professor Shamim. Professor Shahid Shamim. Announce correct?
Professor Shahid Shamim. He is a professor and director of postgraduate studies, Faculty of Surgery at Aga Khan University. He is PGD Bioethics, MHP and PhD in Medical Education. Professor Shahid Shamim.
Thank you very much. When I was called for this talk, it was 20 minutes. Then when I came here, it became 15 minutes, then 10 minutes, and now I've been told that in 10 minutes that we have two speakers, so in 5 minutes I have to finish my talk. So I've hidden most of the slides. I'll just go from the beginning, a few slides in the middle, and then suddenly you'll see the conclusion slide, so please don't mind that. So we have been talking about training and training of colorectal surgeons, and I think it's really heartening to see that we are talking about training, because I think and my talk is about training surgeons for 21st century. What is 21st century? It's the time from January 2001 when I started my career as a surgeon after doing my fellowships, and it will go up to 2100. I'm sure many of us would not be here to see that, but we are training surgeons for 21st century, while we were trained in the 20th and 19th century by the ways that were created in probably 18th century or before. And things have moved on after that tremendously. We are talking about colorectal surgeons. We are talking about people who are, we are talking about trainees who question now not like the trainees who used to just keep their head down and do whatever they were supposed to, they were told to do. And we're talking about professional demands where, the disease processes has changed, the treatment plans have changed. We go by the book now, we go with, it's not on the whim of a surgeon who would decide what to do. It has to be a multidisciplinary team which decides. The apprentice is no more a loyal apprentice like a loyal dog. You kick him, you hit him, you abuse him and or her. Well, they were not surgical trainees heard at those times, but now you see a lot of females, girls, very, very dedicated and motivated female surgeons we are going to be seeing in future, and we are still seeing now also. So, and the professional demands have changed. Research and technology has taken a lot of things over. So the skills that we need to impart to our trainees in 21st century are not just surgical skills, are not just operative skills, because they have become like mathematics now. If it's a T1 N0 tumor, this is what you need to do. If it is a T3 tumor, this is what you have to do. But there are so many other things that you need to give to them, which probably never were thought of in the 18th and 19th century, but for the 21st century, they have become necessary skills that needs to be given to trainees. Like Socrates developed Plato, and Plato developed Aristotle, and all of them developed Alexander the Great. I mean, somebody who had never picked up a sword is developing a person who is conquering half of the world. This is what mentoring is. And to create someone like that, we need to have people who know how to mentor others. It's not just supervisors. CPSP registrar is here, and I'm so glad to see him. It's always a pleasure meeting, sir. But we need to come out of this one supervisor, one trainee arrangement, because that was 18th century apprenticeship model, which we kind of twisted into kind of a structured training program. But it is not a structured training program, because structured training program needs a structure. It needs something which holds everything together, and which needs different pillars, not just one pole. So, and when we talk about mentoring, we need people who can support self-assessment. Mentoring does not need to have, it's not about assessing your trainees. It's about equipping them to assess themselves. It's about professional maturation. It's about psychosocial functions. And on top of everything, I think it's about reflection and feedback. We need to have trainees who can reflect, who can take feedback and reflect on that and work on that. And for that, how mentoring paradigm has changed. Even mentoring paradigm has changed over time. Like in 20th century, when I was a trainee, the mentoring means somebody was trying to add value to my training. But now it's a responsibility. It's a necessity. It's a requirement. It should be a professional requirement. The accrediting bodies should create this requirement. It's a reciprocal relationship, not a top-down approach, not like a professor teaching or kicking out a training. It used to be a one-to-one approach, one supervisor, one trainee, one mentor, one trainee. But now there's so much width and there's so much breadth in the training, in the specialities, that it is impossible for one person to be an expert of everything, except for Dr. Tahseen's friend, who is a cricketer and does everything well. But there are such good surgeons in every hospital, in every unit, but they are experts in their own fields. Expert in one field does not make him an expert of football, cannot be teaching cricket. Or a bowler cannot teach batting to even in one game. So in surgery also, it has become so wide that we need multiple trainers, we need multiple mentors rather than one supervisor taking the person throughout his training process. And mentoring or training used to be early in career, and then but now, as Dr. Tahseen is saying, that people call me, people call Dr. Tahseen, people call all of us from different places, and I call my supervisors who are now retired people, and I take their advices, and this is a lifelong process. So it's not about having one supervisor or having supervision for from one person or in one place also. Like somebody was saying here that different hospitals are doing different things in a very, very tremendous way. And so whatever is, why can't our trainees go to different hospitals for their training? Why can't they train? Why do the training has to be just stay within one hospital, one unit with one supervisor throughout his training career or her training career? Why can't they visit Dr. Tahseen and Dr. Sumro and Dr. Kamran and everybody in the city or maybe outside the city for getting that particular competence which they can get best from that place? So as I said, that I'll jump to the conclusion slide as soon as possible. So we need to understand the roles of supervisors and mentors. We need to be very clear on how gender, age, time is a very important issue, because we talk about a large pool of patients and diseases in public sector hospitals. But the problem in public sector hospitals is the work starts at 8:30 in the morning and finishes at 1:30 in the afternoon. You cannot train people in 4 hours of working, and especially when you have 4 or 6 residents and fellows working with you. So maybe if we cannot increase the number of hours because of the system, maybe if we can increase the number of trainees, then that problem can be sorted out. So we need to think about these things and how these things can be addressed to get the best out of it. Yes, supervisors can also act as mentors. It's practical, but can we have more mentors? Can we have different people mentoring for different things or different procedures or different expertise, bringing expertise? And the benefit, mentoring brings the benefit for trainees, and it is very good for career progress and academic progress, but you need supervisors also. We have to think about people who can be supervisors, people who can be mentors, and we have to have a pool of them. And that change is going to bring the change which we require in the 21st century for the skills that our trainees will require after we are gone. And they would be making trainees, making surgeons for 22nd century, which will probably have more challenges. And this tree can only flourish, or we can only take it forward if we have a combination of supervisors and trainees and monitors, mentors, and different places. And that is something I think that we need to start thinking about. And I'm sorry for going so fast, and so I don't know if the message has gone across or not, but the take-home message is that the way we are training our trainees at this point in time is 18th century programs, maybe slightly modified here and there, and to go into the 21st century and taking it forward into forthcoming centuries. I think we need to relook on our training programs. We need to relook on our rotations. It has to be collaborative. It has to be with a number of mentors and supervisors for everyone. Thank you very much.
Thank you, Professor Shamim. Now I would like to request Professor Haris Rashid. Professor Haris Rashid is currently the chairman of Department of Surgery and Allied at all campuses of Ziauddin University. He is a general and laparoscopic surgeon with expertise in performing critical care surgeries.
We can do this one. Assalamu alaikum ji. I can easily feel the tremendous pressure on Dr. Khushi. Then he requested me to cut down as much as possible. 4 o'clock they're supposed to return this hall, and if they won't, it's a big penalty on him. So I understand we have arranged a lot of this kind of a program, and I'm just cutting off my talk, just hardly 1 or 2 minutes. So, before I'm going it, let's come to the conclusion. It's very easy to say about the colorectal screening, but if you go for implementation, and if you go for get the objective, it is very difficult, especially in the country like Pakistan. We don't have a database. We don't have the education about the screening. We don't know exactly. A lot of people, as a key point is that a lot of young generation involving in the colorectal preventable, but we don't have the proper screening. That's why we're losing all these patients. So, how are we going to get this? Okay. No. जवाब दे दिया हो गया okay in the Pakistan, if you go have a quick look in the Pakistan, that the female ratio and about the men with the cancer and the rectal, so we have some figure. A lot of these slides is we take that material from the different recently published papers. So if you go on furthermore, so overall the prevalence of the colorectal cancer is 5%, and the tumors and the sigmoid cancer diagnosed delay is a high rate. So what we're saying is 44.2 and 38.9 per the patient were diagnosed stage 3 and stage 4. So this is just a slide where you can see that, you know, there's a sigmoid cancer, rectal cancer, and a colorectal cancer in the different stages. The risk of the colon cancer, we all know the risk about the colon cancer, and the risk of still the lifestyle. And this is all basically much more we are talking about that in the Pakistan, what we have in Pakistan, and this is how the screen, we preventable this cancer, and this is the most important part in this presentation. The colon cancer screening, why is it important for us in our community? We talk about the Pakistan here. So the leading cause, we reduce the incident and the death of the disease. Screening can detect the disease early and also prevent cancer for removal of precancerous polyps. So this is what we have, the tools, investigations, colonoscopy and the sigmoidoscopy, and obviously we have the FOBs. So the screening, why it's important, we don't have the DNA screening here, but just say, I'm telling you that if it is possible, then in the rural areas, we have this test, we can go ahead. So HG suggestion, we have these suggestions. I'm not going into these suggestions because we all know about that. So when we have to do the colonoscopy and when we have to call the patient for the other investigation, and what's the outcome? So it is a long-term outcome, survival rate, compared with the non-screen patient, and the hazard ratio. That's the hazard ratio is important here, which is they have seen about 0.48%. So the outcome again is that the screening, the positive association with the favor of CRC patient, and that between the 50 and 70. Again, the additional advances of the high accurate, non-invasive, acceptable screening are needed to improve detection and prevention of this disease. Incident. That's one of the things that after the screening, that the incidence goes down here. We don't have any documentation in Pakistan. The main concern, the prognosis is even worse when the disease occurs in young adults due to the advanced presentable disease. In my case, I have a patient is a 17-year-old. In last few months, he presented with the rectal cancer. All the general physician, healthcare people, they should not avoid all these kind of signs and symptoms. Barrier of CRP, how we have a difficulties in Pakistan, and we don't have the one window operation. A lot of time we have to send the patient to gastroenterologist because the most of the surgeon here, they're not performing the endoscopy procedures themselves. So that is one of the reasons. And again, there is a language barrier. They have no government support, and the rural health centers, we don't have this education. So how we can increase the compliance? There's a strategy, and the strategy is the population about the importance of undergoing screening tests and achieving high efficiency from the test, developing new sensitive efficiency screening methods. So what's the conclusion? I just tell you in 2019, I have been called in Islamabad. And the thing is this, they wanted to launch the national screening program. And it was my privilege that I would be considered one of the surgeons to come up and give us some details and some, blueprints. So we were very happy that, like the breast cancer screening program and the other screening program, now the Pakistan is coming into the era where we are starting on the national level. So we work very hard around, say, like about 3 months, developing the blueprints and all this. And then they told us that the support and the finances from the outside, and they have a good, huge resources. Then it ended up the final meeting with the Minister of the Health. Minister of Health is the political guy, and he said that पैसे जो हैं वो इधर आए ज़रूर थे, मगर दूसरी चीज़ों में ख़त्म हो गए. तो द इम्पॉर्टेंट आखिरी कंक्लूड ये है कि मैं एक अकेला सर्जन या आप अकेले सर्जन जहाँ पे हम एक अकेली स्क्रीनिंग एक पेशेंट के ऊपर करते हैं, दिस इज़ नॉट इनफ. हमें अगर इसका एक अच्छा रिस्पांस चाहिए तो नेशनल लेवल के ऊपर हमें बहुत ट्रेनिंग की ज़रूरत है, फंडिंग की ज़रूरत है, सेंटर्स की ज़रूरत है. थैंक यू.
Thank you, Professor Haris Rashid. And this was the end of our third session. Thank you all the panelists. And I would like to move towards our today's compares, Ms. Saja and Mr. Hussain.
Now I would like to invite Professor Mujibur Rahman on the stage to distribute certificate of participation among the panel of experts and speakers.
Professor Kamal Balot, sir, please can you come forward and receive your certificate of participation? Professor Asif Qureshi, sir, please can you come forward and receive your certificate?
Third.
Professor Farhan Zahir, can you please come forward and receive your certificate of participation?
Now speakers, Professor Tahseen Qureshi, sir, please. Dr. Raza Sayyed, sir, please receive your certificate. Professor Abdul Razaque Shaikh, sir, please come forward. Professor Shahid Shamim, sir, please come forward and receive your certificate. Professor Haris Rashid, sir, please. Now the moderator, Dr. Rubab, ma'am, please.
सर सो के आई हैं, रुबाब सो के आई हैं.
Now I would like to request Professor Farhan Zahir. He is a renowned laparoscopic general surgeon in Karachi. Sir, please give your closing remarks and vote of thanks.
Assalamu alaikum. On behalf of COLOCON organizers, I would like to thank all the eminent speakers, the panelists, all the audience. It was a great learning experience from you, especially Dr. Amjad Parvez Cheema, Professor Tahseen. It was a great learning experience. I would also like to thank all the organizers of the workshop. Have done a wonderful job in arranging this conference from the scratch. It was a great job. Well done. I would also like to thank all the media partners and the partners from pharmaceutical industry for their contribution in organizing this workshop. Thank you very much. Thank you all. See you tomorrow morning.
It's been an honor to be among such accomplished individuals. I would like to start by thanking the speakers for excellent, informative, thought-provoking talks, and the audience to grace this event with your presence. I hope it was a good use of your time.
Ladies and gentlemen, we will meet you all tomorrow. Thank you all for your patience. I wish you all a very good evening.
Allah
Take
Hafiz.
care and Allah Hafiz.